All right, so some people trickling in, which we'll be sure to get to, but I'm Christian Rose. I'm going to be moderating the session. Machine Learning in Point of Care Ultrasound, What's in it for me? Presented by our amazing speaker, Srikar Adhikari from the University of Arizona. I'll kick it over to him to start over the talking. Feel free to put any questions in the chat and I'll try to get to them later.
Thank you, Christian. I want to thank everybody for joining the session. I know it's late in the day, I think 6 o'clock and 6 p.m. in the East Coast. So I appreciate you joining the session. And I also want to thank AEUS for the opportunity to speak. Here are my disclosures. I do get some funding from EMF for grant support, and then I do some consulting for GE, Philips, and Wave. So this talk is not about, it's not a technical talk. Some of us have already attended a lot of AEUS talks talking about the technical language about supervised learning, unsupervised learning, reinforcement learning, convolution neural networks and whatnot. So this talk is not about the technology behind developing AI tools. This is more, you are seeing a rapid explosion of AI tools in the POCUS world. So what does exactly that mean for our practice? Not just for ultrasound enthusiasts, just in general for the EM community, what does that mean? So that's what I was trying to see if I could, in fact, raise some questions in the talk. So my goals are to review some of the benefits of machine learning algorithms in the POCUS world, or I should say AI POCUS tools, and also some pitfalls associated with these tools. I will quickly review some existing evidence and also go through some of the tools which are commercially available for use as of today. So in my opinion, the AI tools in the POCUS world should not give you binary answers, yes or no. It should do something beyond that, meaning, so if you're looking for pneumothorax, it shouldn't just say yes or no pneumothorax. It actually should be highlighting the regions of lung sliding and say, these are the region. This is the reason why I'm saying that there is pneumothorax or no pneumothorax. So there should be something beyond that. And it should be accessible at the point of care, not like a QLab where you have to go to a computer where you have to analyze the data. It should be available bedside. And it should be a part of the workflow, and it should give instant feedback to the user who is actually at the bedside. And then it also should learn from its own experiences and mistakes. That way it gets better over the time. Broadly speaking, AI tools in the POCUS world, they have to do with either image acquisition or interpretation. So it will help with the diagnosis of something, like, again, giving an example of pneumothorax, and then also maybe sometimes help with obtaining very time-consuming measurements like cardiac VTI. In some cases, maybe even help with providing treatment, for example, like guiding a needle to do a procedure. It could be useful for based on your experience. If it's an expert, maybe it will save you time to get that cardiac VTI. If somebody is a novice, that would help probably to increase your confidence as you are trying to make a diagnosis using the AI tools. So the benefits I see are it could be more accurate, maybe in some cases if you don't have that expertise with ultrasound, and probably would increase your efficiency, leading to increased productivity. And also in the same, when you are efficient and productive, the department throughput might get better, and then that will probably decrease the healthcare costs and potentially improve patient outcomes. What is our dream device, ultrasound device? The one which has all these AI tools in a handheld device, and the one which could be used by an operator with minimal expertise. That's our dream ultrasound device. I know a lot of vendors are focusing on this at this point. That's what they're trying to do, have a team of engineers working on these AI tools to integrate into a handheld device. So let's look at some of what's been published so far. What is the evidence? Is there any evidence for using these AI tools? A lot has been published as of today in terms of like recognizing the B lines or quantifying the B lines. With COVID, the lung ultrasound just took off. People are just, they want to do lung ultrasound. They want to get these lung ultrasound scores. In some cases, they're making a diagnosis. In some cases, they're prognosticating patients with COVID and whatnot. So lung ultrasound is one of the widely used applications, as you all know, in the recent months or maybe in the past year. So a lot has been published in terms of, and there are like networks created across the world in terms of dumping your data, so people can use this large database of images to see if we can identify and also quantify the B-lines. So to give a few examples, not extensively going through the studies, here is a study published by Dr. Chris Moore's group. They looked at an algorithm which can identify unquantified B-lines and compared to sonographers, expert sonographers. This model performed really well in the study with a sensitivity or specificity of more than 90%. So again, these are very these studies are in preliminary stages. And again, there is another algorithm. They looked at the healthy volunteers with normal common tail artifacts and the ones which have actually pathological B-lines in patients. Again, this algorithm is geared towards recognizing and distinguishing between these healthy volunteers and patients. Again, this algorithm performed really well in this small study. Again, one other study which also looked at localizing the B-lines using an algorithm, and all of them compared to the expert sonographers performed well in this small study as well. Besides B-lines, there are other studies looking at other findings in point-of-care ultrasound, like for COVID-related findings. So that's also being investigated in the literature, and there is some evidence for these algorithms performing well against expert sonographers. So we talk about B-lines and quantification of the B-lines, and especially in the COVID world. Now, look along those lines, continuing with the lung ultrasound, there are other algorithms which have been published to recognize the sliding lung sign. Here the investigators in this study looked at the ability of the algorithm to recognize pneumothorax using a porcine model. Again, they compared to the expert sonographers. This algorithm performed well with a sensitivity of 98% and specificity of 95% in recognizing if there is a sliding lung sign, yes or no. In this pilot study, they actually took a bunch of archived images. They used the same algorithm which was developed in the porcine model, and now used in this archive of images to recognize the pneumothorax. And against the expert sonographers, it came up with a sensitivity of 80% and specificity of 87% in this pilot study. Switching gears slightly from pneumothorax to abdominal ultrasound, there is a small study published as of today recognizing free fluid in the abdomen. This is really, really small study. I think they have done like 10 fast exams with positive results and negative results. Altogether, only 20 studies. However, the algorithm performed well in all of these, recognizing exactly what they are, whether it's positive results or negative results. As of today, I haven't come across anything in the fast exam. This is the only study published as of today. Besides lung ultrasound, a lot has been done in the point of care world if it comes to echocardiography. People have done a lot of investigations in acquiring the images as well as interpreting the cardiac ultrasound images. So here is a study, is a prospective observation study looking at the ability of novice sonographers who never had any experience, didn't have any experience acquiring echocardiogram, any images, and see how well they can acquire diagnostic quality images using an algorithm. So these are 30 nurses, they acquired images in 240 patients. What they found was they found that all these images obtained were of adequate diagnostic quality when it came to determining LV size and function, recognizing pericardial effusion, yes or no, and then right ventricular size as well. It is very attractive, like I said, if you have an algorithm that could be blended into a handheld device, and that would make dream come true for all of us in terms of, especially, I believe, point of care ultrasound, if you have an algorithm, that should be, I think it's more so than ultrasound enthusiasts, it's more so for other people who don't have the expertise. I think that's where you can make the greatest impact. Here they have used an algorithm which can make the measurements, MAPC measurements, using a handheld device, and it did fairly well in terms of correlation. And continuing with the cardiac theme, again, they picked up novice sonographers and used an algorithm to see if they can accurately estimate ejection fraction. Again, the algorithm did well in this study as well. And continuing with that, finally, I want to add a note. IVC. I know the literature is controversial. However, there are so many tools which have been developed commercially available right now. And there is some evidence published about the collapsibility of IVC, how well the algorithms are published, how well the algorithms perform in the real world. So a lot of stuff has been done on the lung ultrasound and cardiac ultrasound and some in the abdominal ultrasound. And a fairly a good amount of literature is available right now for vascular access. In addition to vascular access, there's also neuroblock studies published. Essentially, they were looking at if the femoral nerve region could be identified by the algorithm so that would increase the safety of the procedure as the novice users are performing the procedure. Same thing with axillary nerve block as well. Can the algorithm highlight the nerves and blood vessels for the operators to accurately identify and guide the needle? So both of these studies have performed decent. One last thing I want to say is about optic nerve sheath diameter. This is of a lot of interest if you're looking for DoD grants and so on. There's some literature that at least 3 publications I've come across looking at automated tools which can measure optic nerve sheath diameter. Besides the patient care algorithms, there's also demand and interest to develop algorithms for quality assurance purposes. Dr. Blavis developed an algorithm which can accurately classify ultrasound images. I find this very interesting and attractive because not all of us have all the resources to provide quality assurance and feedback and so on to multiple users at your shop. So I think algorithms like this would be immensely helpful I'm keeping track of the time so that I don't go over, to be immensely helpful to provide the feedback and for training purposes. I think one of the vendors also developed an algorithm I have come across. So I think these are, important for education purposes as well. So I talked a lot about benefits and I talked about what's been published in the research, but I think there are some, or I should say definitely some risks associated with using these algorithms. If you, like anything else in life, if you don't understand the limitations of the algorithm, then you potentially might harm the patients. And one of the other disadvantages with algorithms are maybe there'll be reduced engagement on behalf of patients and physicians if you start using algorithms, and maybe we won't participate as much in medical decision making. And also, is there any risk for unauthorized use of any PHI and HIPAA violations and whatnot? So there are definitely some risks associated with artificial intelligence. So the big picture is, the big question we have to answer is, do we need something, an algorithm like our like our defibrillator, where you can slap on the chest and it'll give you an answer and you go with that and you shock? Is that really what we want? Or do we need something like we can use this as a piece of information along with other clinical variables and make a much more informed medical decisioning? That is something we have to answer moving forward. That is what we have to focus on the research. So what I wanted to say is, if you look at most of these algorithms, they're developed based on the imaging data. So people are dumping images and they're doing, but nobody's actually, I shouldn't say nobody, many of these algorithms are not developed based on what's the clinical data and the patient outcome associated with these images. I think that is key as we are developing these algorithms, to include the data so that I think our algorithms are going to be much more efficient and accurate if you do that. So let me quickly review in the next few minutes here about the existing AI tools. These are all commercially available. I'm not naming any of the company names here. So there is this software available which will guide you to acquire the images and also tell you how good your image is and also help you with interpreting some of these images. So it will provide you real-time guidance to navigate you use your transducer to make all the required motions to obtain quality images, and it will automatically calculate your ejection fraction, the patient's ejection fraction, with any combination of images. And there are actually visual cues on the machine as you are scanning. It will give you feedback. So I think it's this, as you can see here, I think extremely useful for a novice sonographer, or you want to provide a guidance from remotely, so you can see how this tool would be helpful for a non-expert sonographer. And again, they'll give you quality meter will tell you how good is your image, and you can, and once it turns green means the image is of adequate quality. Again, there are other vendors which who have developed similar tools where they would guide you to develop, they'll guide you to, again, move your probe to get an adequate image. And not only the algorithm guides you to get an adequate image, but also it grades how good is your image, and also it provides some labeling on the image. I think these are not only good for patient care, but also, like I said, good for quality assurance and education purposes. And this new tool, I'm sure some of you already seen it, which is called the long sweep tool. Essentially, it gives you a panoramic image of a number of lung intercostal spaces. So it, potentially you could be using this to diagnose pneumonia. And again, there's a lot of interest in lung ultrasound right now. This would be convenient to scan, especially in a kid from top to bottom, in whatever intercostal spaces you choose to do so. So it'll give you a summary of it will give you an accurate image of all the intercostal spaces. And then again, several tools are in place to recognize and quantify B lines. Here's a tool which automatically, I'm very impressed with this tool. It automatically, when you place the cursor in that area, it locates the LV outflow track and gives you this auto VTI calculation. Again, we are all familiar with the collapsibility index, where these auto tools quickly pick up the IDC and give you this collapsibility index. This is fairly recent one, which actually gives you a real time, meaning you don't have to freeze anything. It will give you real time EF as well as stroke volume. I find this very attractive when you are looking for fluid responsiveness and whatnot. And this is another vendor who developed using the Simpsons method, both in systole and diastole. They would calculate the space endocardial the Simpsons technique using both in systole and diastole, the chamber space, and then they would come up with the accurate stroke volume. So what's in the pipeline? I know some of the vendors are working on hydronephrosis and RV function and whatnot. So there are several tools probably coming up in the near future. Again, the impact of these tools are going to be very much dependent on how we can integrate them into our workflow and also into our clinical training and practice. How cost effective are these tools? How well they can mesh with the regulatory and reimbursement policies. Are there any medical legal implications of using these tools? These are all the things which would impact, decide the impact of these AI tools. To summarize, I think all the AI tools, unless they should be integrated into workflow, and they should be providing instant feedback, and they should be taking into consideration the clinical data which is available, and also they should address real world problems. And that's when it's going to make the highest impact. And then industry researchers, clinicians have to work together to move this field forward. And I think not only patient care, but also it would serve well for education purposes as well. With that, I'm going to stop. If there are any questions or comments, I'm happy to take it.
Wonderful presentation. That was really great. One question from Sam Lam was about the initial B-line predictions and whether or not those were done in real time or from image review.
Yes, some of the studies were done on image review, if you're talking about the published studies, and some were done real time, but the commercially available tools are, they do it real time, to my knowledge.
Then there's a question from William Bond, which goes to the quality assurance and NLP. I was wondering if people have done any NLP studies on the notes, for example, fast, negative, CT also negative, doing any quality checking in those areas, maybe on the reports, I think might be what he is referring to.
So
and maybe seeing how they match up maybe with the images.
Right. So very good question, because most of the quality assurance is done based on the image data, but not looking at the outcomes data and how it compared to the other imaging data. I think that's a great question. And I think that's where this slide actually shows they integrate the clinical data. I think that should be our goal eventually. I think if we just look at the image data, I think we're going to be somewhat handicapped. That's a great question, and I think that's what we should be doing moving forward.
Erica Constantine, are you aware of any AI being developed that is relevant to the pediatric population?
The only tool I am aware of at this point is for that lung sweep. I think it really works with the pediatric patients more so than adults, because the real estate is small, so you can really cover from entire hemithorax quickly, and you can do the lung sweep and decide if there is any underlying pneumonia. That's the only tool, and besides the vascular access.
The one I keep thinking about to that topic is the API or even the intussusception. They're really hard for providers to do, but you're picking up a target. And so it feels like something that might be right just when thinking about what kind of questions ultrasound AI could help with. But I haven't seen that yet either. I don't know if you have.
I think that's a great point, Christian. I think there'll be a significant interest for appendicitis. I'm not sure because most of the vendors want to put the money where the disease and intussusception. I'm not sure if they want to put their money in there. But I can see the difficulty in making the diagnosis and why we would need that.
I say that completely as an overnight nocturnist ER doc who sits there scratching my head saying, I guess I'll wait until 7 a.m. when an ultrasonographer comes in.
I get it.
All right. Looks like we've got to wrap this up, but thank you again, Srikar. That was a great presentation. Really appreciated your time and looking forward to hearing more next year. We'll see how it goes.
Thank you, everyone.